I'm a mainstream oncologist, so I just poison people and shine radiotherapy at them and stick radioactive seeds into their prostates and things. So I'm very much under qualified for this audience. But I'll try to share with you some of the research we're trying to do in our unit, and you can judge for yourself. The incidence of cancer is going up slightly, but fortunately, the number of people being cured from cancer is actually improving quite dramatically. This is a graph produced by CRUK, which shows the survival rates of cancer, which are improving over the last 10 years. For example, when I first became a consultant, I treat breast cancer, bowel, and prostate. The chance of surviving breast cancer was about 54%. This was 14, 15 years ago. Now the chance of surviving breast cancer is 84%. So there's significant progress in medical interventions, surgery, radiotherapy, Herceptin, things like that. But what that means is that there's many more people living with the consequence of cancer and cancer treatments. This is a very good This was a very good collaboration between the American Cancer Society and the National Cancer Institute, which looked at the increasing number of survivors. Of course, most hospitals don't keep any records who they treat. They just go off to the big wide world, so it's difficult to get the data. But they've estimated that in America, now there's 12 million cancer survivors walking around. In the UK, 2 million, and that incidence is going up significantly. And put it in perspective, they feel that over 65-year-olds, a quarter of the population would have actually had cancer and gone through cancer treatments. Now, it's good to cure more people, but unfortunately with conventional treatments, the toxicity is quite incredible. Most people are living with some degree of fatigue, psychological changes. You mentioned about psychological intervention. We have no psychological backup in a mainstream oncology unit in Bedford, for example. So, depression is common, poor appetite, chronic constipation, weight gain amongst the breast cancer, and not to mention financial and marital and social strains. So just treating someone and curing someone is only part of the story, yet we're told every day by the NICE committee and the government that, once you finish treating someone with breast cancer, you discharge them. And that's what I do. I say, hello, you finished your chemotherapy, goodbye. And that's it. That's their follow-up. And more they're telling us that that's the end of the treatment, which of course it isn't. Anyway, I'll come more onto that later. But you mentioned about the incidence of cancer going up. The World Cancer Research Fund recently produced a document saying that they feel, based on environmental studies, that 50% of cancers in the world could be prevented by lifestyle, changing your lifestyle. So, just think how much money you would save, in the world if you managed to get people to... And these were just the common things, because statistically it's easy to look at alcohol and obesity and smoking. And you mentioned other things which are less easy to prove, but almost certainly they have an effect, looking at the amount of xenoestrogens and things in the diet and pollution, which is going up all the time. There was something in ASCO News yesterday's thing saying they're very worried about environmental pollutions causing cancer, particularly in big cities. But what about after cancer? Because at the end of the day, most people unfortunately most youngsters feel they're invincible and they're not going to change their lifestyle. But you do have a thing called a teachable moment. You have people who've developed cancer, and they're often willing to look for other therapies and how can they help themselves. But many oncologists would say, well, look, cancer is a genetic disease. You're born with the cancer in your DNA, and your environmental factors switch your genes around, you get your cancer. So it's too late. You just need chemotherapy and surgery. What you do is not going to prevent that cancer relapsing or progressing. But of course, none of us believe that, do we? Obviously, thank you. So obviously, I've tried to look at some of the evidence in my book and website and work with charities like Macmillan, who are now embracing lifestyle, and they're actually doing they've got a survivorship program, which is particularly looking at exercise. So it is becoming more popular, particularly amongst patient advocacy groups. But I have to say, it's not yet infiltrating into mainstream oncology practice. So how can once you've got your cancer, how does it make a difference scientifically? As I said, cancer is so there's no laser here. Cancer is a genetic disease. We have it in our genes already. The cells are formed, but for that, we actually form cancer cells every day. I mean, I'm sure you know that. If you go and eat a sort of a cream cracker or a parsnip crisp from Boots or something, the acrylamins go into your body. You switch, your cancer's formed, but our immunity fights it. So thousands of cancers are beaten off every day. So for it to get to a cancer cell, to metastasis to the, say, liver or bones and kill you, there's a whole series of pathways it has to go through. It has to grow faster, it has to de-differentiate. In other words, it has to look very different to the organ it came from. It has to lose its stickiness to the site of origin, called adhesion. And if you lose your stickiness, it then metastasizes. It has to form new blood vessels into it, called angiogenesis. It has to invade other organs, and grow to an extent that it compromises your normal bodily functions. So all that pathway, which is the vast majority of it, it can all be dictated by your hormone levels, further intake of carcinogens, and your immunity. And that's the bit which we can have an influence on, as you've just heard. And is this new? No, it's not new. As you say, Gerson's been around for a long time. Even on the medical side, Stephen Paget, back in the beginning of the last century, actually said, while many of us look at the seed in terms of research, the seed, in this analogy being cancer, you should be looking at the soil, because all good gardeners know you can have nothing grows unless you have the soil to help it grow. And medics aren't all bad. The EJC, which is a very good scientific community, just published last year 50 years of oncology achievement. And things like Herceptin are fantastic. It's curing millions of women around the world. They all acknowledge that. But their conclusion, which was quite a surprise, was that we should stop doing research trying to kill cancer cells, which is quite a surprise. Because we all have cancer cells every day, and they're part of our body. So why kill part of our body? What we should be looking at is finding ways, why are we giving permission for that cancer cell to grow? Because we're allowing that cancer cell to grow. That's what you should be concentrating research on. Because we can't kill every cancer cell, but we can say to the body, stop giving permission for that cancer cell to grow. And that was in a mainstream oncology journal. And if you look at the JCO and journals like that, there's more and more research on this sort of thing. And even the JCO has now got a complementary section, which is very rewarding. Or it's almost impossible to get a paper published, but that's another story. So what are the factors? Well, I'll just go through them very, very briefly and concentrate on some of the research which I've been trying to do. Exercise, number one. Particularly for symptoms. So if you can get a patient who's been through chemotherapy, Herceptin, radiotherapy, to go into an exercise program, does that improve them? Well, yes. Despite what many oncologists say, there is lots of randomized controlled evidence that patients who exercise after cancer have reduced fatigue, reduced mood and anxiety. And of course, there are papers which show that if you are depressed and are more anxious, you have a higher relapse rate, you have greater muscle power, and overall quality of life is improved. So there's no debate scientifically that exercise programs work. So when you say to your PCT or your healthcare providers, I'd like to introduce an exercise program, please, because there's randomized controlled evidence published in the BMJ to support it, they say no. So it's difficult. And when in parts of the country like Liverpool, which have embraced it, and Preston, which do have exercise programs after cancer, they've reduced the funding from £110, that's all it is anyway, for a 12-week program, down to £68. So, this is what you're up against. And it's not just the British evidence. There was the American Sports Association looked at 85 randomized controlled trials and showed that if you can get people to exercise after cancer, you have better self-esteem, the fear of relapse is reduced, better body image, etc. So there's lots of data. Just closer to home, probably about 5 times a day I castrate men, not physically, but with drugs called Zoladex. And when you give Zoladex to men, they put on weight, they get moody, they get hot flushes, and several randomized trials, such as this one, shows if you can say to men, if you exercise at the same time, you don't put on weight, you don't get moody, and their quality of life is maintained. And there's a thing called metabolic syndrome where they get abdominal obesity and actually their sugars go up, and that actually is a risk factor for cancer in itself. But how many people in the country give someone a prescription for Zoladex and a prescription for exercise? No, well, I do. They all think I'm slightly mad in Cambridge, but it just makes sense, doesn't it? You know, you say, go to the gym and have this injection, and they're fine. And they don't get the side effects. But anyway, that's a simple thing. We may give people osteoporosis regularly by withdrawing estrogens or androgens in men, and it's a big problem because if you fall over when you're elderly and break your hip, it might be even fatal. And we think, well, you take calcium and vitamin D, you give everyone calcium and vitamin D. And how many people know someone on calcium and vitamin D? And did you see the news yesterday or last week? Well, which is not a surprise, because there's actually no evidence at all that calcium vitamin D supplements helps osteoporosis. But it's still given. So the same people who are saying, oh, you can't recommend exercise, are then recommending calcium vitamin D with no evidence at all. There was a trial this week published from Australia which actually did look at calcium vitamin D in a randomized trial and showed no evidence. So not only was there no evidence, there's now trials showing there's no evidence. So, but anyway, so bisphosphonates help, of course, which is where you actually give something to remodel the bone. But again, bisphosphonates on their own work to a certain extent. Bisphosphonates and exercise work 5 times better. So again, it's really the exercise is the important thing. And this is just a trial showing that if you exercise, you increase your bone density. So there's real data to show that. But of course, exercise isn't the only thing. The classic one is that people think, well, you need lots of protein, so they eat lots of meat. It's actually plant protein is better for bones, not animal protein. And that's been proven in trials as well. And essentially, the only thing is being overweight is actually good for osteoporosis. So that's the only thing that being overweight is good. So being very thin is not good. We did a trial in Cambridge where we looked at every single alive man who'd been treated with radiotherapy over the last 10 years. We had a research student from Oxford to help us with this. And we got 440 men. We sent them lifestyle questionnaires and we asked them about their late toxicities, which was actually quite interesting as well, because when we go to the patient comes into clinic, you say, how are they? They say, oh, I'm not too bad. I've got a bit of a problem with my bowel, but I'm not too bad. You actually send them a questionnaire which says, are you fecally incontinent? And they say, yes. And you go, oh, wow, didn't realize. You know, so the more you ask, the more toxicity you find. But anyway, that's a bit of an aside. And what this showed, though, that if you looked at their smoking rates, whether they were old, or whether they had, whether they were overweight, or whether they exercised, the strongest correlation statistically, whether they had late effects, was the amount of exercise they did. Age was not a correlation to toxicity, interesting enough. But exercise, if you exercised, you had reduced rectal toxicity, you had more continence, and you had better erectile function. So, as I said, you've probably heard the joke before, but if you want more action in the bedroom, you go and buy some training shoes, not anything else. So what about relapse rate? Well, there's no doubt that exercise helps toxicity. These are 2 studies, one from Australia, one from USA, which looked at, these were actually people in trials, but not the primary endpoint wasn't exercise, but they went back and looked at exercise. And they showed quite clearly that if you were an exerciser after bowel cancer, you had a 14% lower relapse rate. And the same finding was found in America in another large study. And if you think about it, chemotherapy gives you about an 8% benefit, whereas exercising gives you almost twice the benefit. The same finding was found in prostate cancer, saying that more than 3 or even up to 5 hours a week, you had a 51% reduction in your risk of relapse. The same finding was found in breast cancer. But they're all these are all large retrospective studies. But again, they all showed about 3 to 5 hours exercise a week, you had about a 30% reduction in risk of relapse. Obesity, well, there's various reasons why obesity is not good. And there's lots of evidence to say that if you are overweight after breast cancer, you have a higher relapse rate. And this was from the Nurses' Health Study, which showed that if you actually put on weight during your chemotherapy, you had a higher relapse rate. So the advice which is given to women is don't worry about putting on weight during chemotherapy because you lose it afterwards. A, they don't lose it afterwards, and B, they have a higher relapse rate. And this is the cynics who say, well, you just correlate, it's not causation, this is not true. This was a very nice study from Klebowski, published in JCO, the world's best cancer journal, which put 2,500 women to an exercise fat reduction and counselling program, and they showed that women lost weight, and the ones who lost weight had a lower relapse rate, and particularly in the more aggressive subgroup. So you can put someone into a program and reduce the relapse rate by losing weight and eating better, and that was a prospective randomized trial. So what about diet? I mean, there's lots and lots of things we can talk about. It's just sort of selected examples, really. We know that if you have a healthy diet after breast cancer, this is again the Nurses' Health Study, which showed that people who ate a prudent diet with lots of fruit and vegetables, high fibre, and I'm not supposed to use the word antioxidants, but in their study they used it because it's quite an old study, but compared those women who had lots of fat and processed food, salt and sugar, and there was a significant difference in relapse rate and overall survival. We know that men with prostate cancer, this is the Dean Ornish data, which we looked at men with prostate cancer, and he randomized them into basically a healthy living program or standard care. The program involved walking and eating healthily, and he showed a significant difference in the PSA rate climb at 1 year. He also, if I got this now, he also in this study, which is quite nice, he took the blood of the people in the study and he added it to cancer cells in a Petri dish, and the cancer cells grew at a much faster rate in the group who had an unhealthy lifestyle compared to the people who were in the healthy lifestyle. So there's obviously things within the blood, which again would be a subject of a completely different talk, which actually you can then transfer into cancer cells and show the growth rate is changing. So coming more now onto the nutrition, and effectively, as we've just heard, it's all about a balance with what we take in. So it has to be, we can't avoid carcinogens. Just walking down Mile Road, we breathe diesel fumes. A lot of the food we eat has carcinogens in, and we can try to avoid it with an extreme lifestyle, but on an average thing, we just need to increase our anti-cancer foods. So on a daily basis, we have more anti-cancer foods than the cancer-promoting foods. And what are they? Well, I'm just doing some examples. These are the common ones in our daily lives. Acrylamines, which are in superheated foods, nitroso compounds in red bloody meat, processed sugar, alcohol, anything smoked seems to be bad. There's other environmental carcinogens. As I say, they're not all man-made. There's viruses, protozoa in Africa, having plaque on your teeth. I mean, every week there's something new which comes out, and we try to summarize them in our newsletter and things. Sunburning, candle smoke, not sleeping well at night, or altered circadian rhythm. They're all carcinogenic processes. Basically, in terms of acrylamines, I mean, it's all on Google, but if you Google it, you can have hours of fun looking at the things with the highest acrylamines. Pringle crisps seems to be the highest thing in our food chain at the moment, which my kids keep on picking off the shelves. There's 6,000 micrograms per gram, which is like way off the scale. But I won't bore you with it. You'll hear more about this from Jane Plant this afternoon. But is there any evidence, if you could say to someone after cancer, reduce your carcinogens and your cancer is less likely to come back? Well, yes, there are. There's a number of studies now coming through, not many, looking at, this is not fat or exercise now, it's just carcinogens. There was one from Japan, which looked at the intake of processed meat, and there was a twofold higher relapse rate in those people. There was an ovarian study, again, looked at meat and high milk and fat intake, and there was a higher relapse rate. Obviously, smokers have a higher relapse rate, this was in people who had head and neck cancer, but smoking doesn't just apply to head and neck cancer. There was another study from Japan with over 25,000 people in it, and it showed a greater relapse rate for bowel and breast. So that's the things which cause the cancer. What's the things could be an antidote? We're just taking a step back. Is it true that eating badly does cause cancer in the first place? Well, yes, there's lots and lots of studies which show that people who have lots of polyphenols and antioxidants and fruit and veg and that sort of thing in their diet have a lower risk of cancer. So that's been firmly established, and even the most ardent of oncologists will generally agree with that. But what about after cancer? As I say, is it too late? Yes, there's a number of studies that people who eat lots of broccoli and tomatoes and spices have a reduced risk of cancer. Yes, there's a DNORNISH I've just described. There was 3 breast cancer studies, and there was a nice one looking at people who had skin cancers and looking at the second, risk of having a second cancer, and there was definitely a reduced relapse rate on that. So being a bit more specific, up until a few years ago, it's changing a little bit. Most breast cancer patients were told, oh, don't eat soya beans and don't eat things with phytoestrogens in because they're estrogenic and they'll promote your breast cancer, which has got an estrogen receptor. The fact that tamoxifen actually is actually an estrogen receptor promoter goes without their thinking. The way tamoxifen works, it promotes, it attaches to the receptor and it can promote some growth, and it can inhibit some growth. For example, it promotes growth in the uterus, but it inhibits breast cancer. Well, phytoestrogens act in a much more natural and similar way. It actually binds to the receptor weakly and stops the growth of the cancer. So it's actually beneficial. And it has other healthy foods as well. And that was proven eventually by the Shanghai breast cancer study, which had over 5,000 women in, and it showed people who ate lots of soya and beans and things actually had a lower relapse rate, not a higher relapse rate. So still, I gave a talk last Tuesday, and there was oncologists in the room, and they were saying, oh, I didn't know that at all. I mean, this is about 5 years old now, and they were still saying they're not to eat those things. Another study looking at... this was a nice one. It measured in the bloodstream the level of lignans, and it actually showed that women who had a higher level in their bloodstream, which reflected their diet, of course, had a lower relapse rate. So quite clear that those works. But as I say, we'll hear more about that this afternoon. But what about putting things into supplements? Now, obviously, that is very convenient if you have someone who doesn't eat very well. You know, could you give a supplement to promote their diet? Or even if they eat well, could you have a supplement to enhance the healthy effects of food? And obviously, that's been a subject of a lot of trials over the years. We know if you're deficient in minerals and vitamins, and you have a mineral and vitamin, it's very good for you. And there's a very classic Chinese village study where they were very deficient in selenium. They gave them selenium, and their incidence of liver cancer plummeted. And we need minerals and vitamins for, our antioxidant enzymes, superoxide diamutase, glutathione, and catalase. They need zinc and manganese, etc. So if you're deficient in those, you have a higher risk of cancer. So what the medical profession then did is say, well, look, if you're deficient in, say, vitamin E, if you take lots of vitamin E as a synthetic pill, mind you, not in a natural form, you're going to get a lower incidence of cancer. So they did lots and lots of studies, and they involved thousands and thousands of people around the world, including the CARROT study, which gave people beta-carotene and retinol after lung cancer, actually showed an increased risk of cancer.
They used artificial, vitamin A, though.
Correct.
Study,
yeah.
Which is not the same thing as eating.
Absolutely. That's
so it's kind of a bit of a false negative.
Yeah, well, that's exactly right. So you've got to be careful with not careful, you know the data. These are effectively chemicals they're giving them, which is trying to mimic the natural form. And this was specifically for lung cancer. There was suggestion that prostate might have been better. The ATBC study showed the same thing with vitamin E and beta-carotene. And I can go through. The largest for prostate cancer was the SELECT study, which gave vitamin E and selenium to thousands of men, and it showed the risk of prostate cancer was higher, not lower. The EPIC study was a nice study, which actually wasn't an intervention, but looked at, with very close questionnaires, your level of folate intake. And basically what it showed, that people who took lots of folic acid supplements with a normal diet were actually taking too much, and they had a higher risk of cancer. But people who had a low intake of folate naturally had an increased risk of cancer. So there's a U-shaped distribution. So we want to be in the middle. We want to have the right amounts of minerals and vitamins. But more worryingly, the extracted chemicals such as lycopene, saw palmetto, they were actually, although there were some suggestions from small phase 2 studies, when they went on to evaluate those in randomized data studies, there was no benefit. So it shows that taking a chemical out of a food and putting it into a pill doesn't appear to be the right thing to do, unless you happen to be deficient in that one particular thing. So what's the general advice you do? Well, the general advice is stick to healthy foods, or you can have what Memorial Sloan Kettering and National Cancer Institute are saying. He said you should take supplements, minerals and vitamin supplements, to correct a known deficiency. And that deficiency might be with a detailed lifestyle questionnaire or a blood test. Now, these blood tests, which are available, are expensive. They're over £300 to get a complete profile. But you can do it that way. And many therapists, some of you in the room maybe, will be offering that. And you then give selected supplements to people who have those deficiencies, so you restore your natural balance. And we've been offering that on our website for about 5 years now. And we have published some of the data, not outcomes in how they do. But it's a nice little snapshot. We've got over 300 patients now of what the deficiencies are. Most people in the UK are omega-3 deficient. And the vast majority are also vitamin D deficient, with 15% having borderline levels, which would be synonymous with rickets. So it's a big problem in this country. The FDA do a nice website. It's not updated because the antioxidant part of food is now becoming a little bit sort of old-fashioned, that food is not just about antioxidants. But it's a nice little... they do a nice little summary of looking at the levels of antioxidants within food, and things like turmeric, pomegranate, green tea, previously goji berries, but now goji berries are mass-produced in China, covered in pesticides, so they've got less antioxidants than an ordinary apple now. And if you can play around with it, if you go onto the FDA site and you put something like blackberries in, and it says farm blackberries has this much, and these are experiments, so they're not just making it up, and wild blackberries have 10 times as much. So on a general principle, if it's wild, if it's natural, if it's organic, it's going to be better for you. But as I said before, it's not just about the antioxidants. Foods have anti-cancer properties because they could be phytoestrogenic, so they block the estrogen receptor. More recently, we found that certain foods actually have direct anti-cancer properties, particularly the polyphenols, which can act on all the things I just said before: proliferation, angiogenesis, adhesion. So they actually are, drugs in their own right, which possibly explains why the data, because people always ask, why does alcohol protect you from breast cancer after you've had it, but why does it cause it in the first place? Well, the carcinogens within alcohol are causing it, but once you've got it, the polyphenols within the wine is probably slightly beneficial. But I'm not promoting alcohol, but I'm just saying that's why you get this discordance of data. So just going through some of the things in more detail. Again, there's, this is not just someone saying green tea is good for you. There is lots and lots and lots of scientific studies where they've looked at cancer cells in the petri dish, added green tea extracts, and I've got some competition there, sorry. And they show, you add it to cancer cells and the cancer cells stop growing and they stop showing markers of metastasis. There's studies looking at meta-analyses of over 5,000 women who drink tea after breast cancer, and they have a lower relapse rate. There are some phase 2 studies showing it can help PSA and progression of CLL. The same applies for Pomegranate, showing fundamental hallmarks of cancer progression are reduced. And there are some phase 2 studies, 3 phase 2 studies showing a reduced progression in prostate cancer. But of course, you've got to be very careful with phase 2 studies because there's so many conflicting things which could influence them. Broccoli, you'll hear more about this afternoon. People who eat a lot of broccoli, they're actually genetic signature changes. So the genes which promote cancer are suppressed, and the genes which suppress cancer are promoted. And that's been proven. Curcumin, there's lots and lots of data. I really like a recent one, which actually only came out a couple of weeks ago, which I put in the newsletter. They got an experiment. It's not nice if you object to animal experiments, apologies, but they exposed rats to a household toxin, which is in most detergents and things. And lo and behold, a high proportion got cancer. If you then put curcumin in their diet, it counterbalanced the toxin. They didn't get the cancer. So this is a direct experiment showing that curcumin has an antidote to toxins in our environment. So what we did, we sat down with the NCRI, the National Cancer Research Institute Complementary Therapy Research Trial Division, and we went through all the data we could find on certain foods which we felt had the best chance of fighting cancer, and we came up with those 4. We didn't include lycopene, we didn't include saw palmetto, because the data actually wasn't very strong. And we felt that if you combine the foods, because they have slightly different modes of action, you'll be fighting the cancer cell from different angles. And also, by not having one particular type of food in it, that you'd avoid a cumulative toxicity if you take it over a period of time. So that's the hypothesis, and we wanted to try and prove it. So we formed a trial committee. We got some money from Prostate Action, and we got it badged with the NCRN, which took quite a long time, I have to say, because that's the National Cancer Research Network official body of supporting clinical trials. And we did the study, which we published in ASCO this year in front of 28,000 oncologists in the main urology session out of 10 selected studies for last year. So it was regarded as one of the 10 most significant studies for prostate cancer. So we're very pleased with that. It didn't actually, none of the authors have any connection with the product. Well, there wasn't a product at that stage. The company who made it now, lo and behold, have formed a company, but we are not connected to that. It's made, the important thing with when you put foods into supplements, you have to make sure it has good manufacturing practice, because there's a lot of bad practice out there. You have to get it off a company who do their own in-house testing to check that it is what it says it is, and it's got no contaminants in it. And it's very, very few companies do that. It's not a legal requirement. So the trial was a randomized trial. Half the men had the supplement, half had an identical placebo. It was double-blind. This was just men with prostate cancer who were on active surveillance, so they weren't on any other treatments, or they'd had radiotherapy and they were relapsing. And the randomization process was well balanced. The recruitment was amazing. We were given, we said we needed 150 to be statistically valid, but 10 months ahead of schedule, we applied for an extension. We got 200 because we just got phone calls every day saying, can I go into the trial? Just shows the interest there is out there for this sort of thing. And these are the results. And not surprisingly, they show that if you were on the intervention, you had virtually a tiny risk of progression. So your PSA went from about 6 on average to about 7. And if you were on the placebo in the same group, there was basically it went up with a rate 63% higher. So these foods clearly have an anti-prostate cancer effect. this was interesting, and it puts it into perspective. At the end of the 6 months, or at any stage, men can opt out of surveillance and opt for androgen therapy or radiotherapy or surgery. And it showed that if you were on the POME-T, the chances of opting out were significantly lower. Now, androgen therapy costs over £1,000 a year, and there's all the associated side effects, and surgery and radiotherapy are very expensive. This costs, according to them, just over £10 a month. So you're talking about a treatment which would save the NHS probably millions and millions of pounds a year. Of course, it's not on the NHS because they don't recognise it. There was no other benefits, and there was no risk on warfarin. There was no difference in side effects. So a few people had some loose bowels, but a lot of them said they felt better with that. But there was a little inkling that people's prostatic symptoms got a little bit better. We didn't specifically measure that prospectively, which was annoying. But just on what they reported to the trials team, there was things like any inflammation. There was one person said this tinnitus disappeared, and that may be an anti-inflammatory property of turmeric. But no overall statistical difference in any of the side effects. So basically, the conclusion of the study, which we presented in Chicago, was there was a large and significant favourable effect on PSA. It was a short-term intervention, so you have to accept some criticism. It was only a 6-month intervention, so ideally it would have been better to continue that. Significantly more men stayed on active surveillance or watchful waiting, so it's likely to be extremely cost-effective. They compared it to the same price of a cup of coffee a week, and it was very well tolerated. The company who supplied us, as I say, we actually bought it off them, have actually developed it into a product. And we are quite excited in working with them, actually, because this is a nice example of how we can get money from people, because we're not getting it off the government. And they've now introduced us to Johnson & Johnson. We had a meeting with them in New York last week to say, look, if they do well as a company, they might well be interested in funding further studies. So there's, we will indirectly, hopefully, get a benefit from that. So the large pharma are now beginning to look at this sort of thing as a potential. But of course, the problem is with patents, and anyone can just copy it tomorrow. So what are we going to do as a trials unit? We're going to look. These are our next series of trials if we get the funding. We're going to look at this in men who are on androgen therapy, because these are not hormonal tablets, so they could equally work if someone's already on hormones. As I say, we had some anecdotal feedback from patients that their joints got better. It was good for anti-inflammatory things. So we're going to actually do a very simple study with a rheumatologist, and we're going to randomize that against placebo for people with osteoarthritis. I mean, there's thousands of people with osteoarthritis. It would be an easy trial to do. We're going to work with the dermatologist, see if they can use this to prevent second skin cancers if someone has a BCC. And again, the same applies for bladder. And ultimately, if Johnson & Johnson want to get on board, it would be a cancer prevention study. This is not all we do in our trials unit. We've just set up a randomized trial looking at exercise referral against standard care. And we've just literally put through ethics an antidote for nail loss during taxotere chemotherapy, which looks at leleshwa, which is an African sage herb, to prevent the nails falling off, which we're quite excited about. If you want more information, if you want to follow any of those studies, we have a newsletter which comes out every 6 weeks, was monthly, but we've slipped a bit. So it just summarizes all the things we can find in the world which relate to lifestyle and cancer, as well as our studies. And if you want more information, we're on Twitter now, so any Twitterers, you can get something. And we still have a website which has some information on it. So, sorry for going over time a bit, but I'm happy to take... Can we take questions? Or?
Yeah, questions. I was part of the EPIC cancer study that you mentioned briefly there. Now, I was with them for about 2 or 3 years, and at the end of that time, I was getting a bit bored with the situation, and I asked them if I could have had any results of the test that they've done already. And they said, no, that's down to our sponsors. Our sponsors want to edit whatever the results of our tests are. Now, are you sure that all this information you've given us hasn't been edited by a drug company?
I didn't realise the drug company sponsored EPIC. I thought that was a government-funded body, but I know you're. Yeah, well, yeah, they're a charity and government-backed. But coming back to your question, if you have, we don't have commercial sponsorship. In the study we did, we got the money off a charity. If it's a pure drug company study, which has to be quoted, which yours wasn't, but if it's just widening the question, they can't have editorial influence, but what they actually do is they bury trials which are negative. So if you do 20 studies and one's positive, that's just by chance. They'll publish that one and bury the rest. So I'm not saying they're crap, but many of the drugs they produce are fantastic, but as you say, you've got to be a little bit careful with pure pharmaceutical studies. But no, they wouldn't have, the CRUK, you have to predetermine how you're going to analyse the study. So for example, in that POME-T study, we have to say what we're going to look at later. So I couldn't then say, I can say, well, there's some interesting things in it, but I couldn't say as the primary endpoint it helps arthritis, because I didn't say that is going to be a predetermined endpoint. So a good trial design will not be able to fudge the data. Okay, well, apologies if I use the word cure, because I'd never use it with patients. There is no time where you can say someone is cured from cancer.
Well, you did say a lot of time.
Yeah, I know. I apologise. I never say it to patients. So because anyone can relapse at any stage. Okay, so even with, what we say is the probability of relapse is very, very small. So for the sake of a presentation, it's easier to use cure because, yeah, clearly many are. But when you, CRUK, for example, do they give 5-year figures, 1-year figures, 10 years figures. That's just an arbitrary time. For the presentation of the data. It doesn't mean at 5 years, if you've lived 5 years, you're going to be cured, because a few people could still relapse after 5 years. But the probability of relapse for certain cancers change. For example, lung cancer, most people with lung cancer relapse within 1 year. So if you live 5 years, well, you're probably cured, because you would have relapsed. Even with breast cancer, if you're ER negative, most people with breast cancer relapse, with ER negative relapse within 3 years. So if you get to 5 years, you're probably cured. But if you're ER positive, most of the relapses occur at 5 years. So going to 5 years doesn't give you that reassurance. So for every single cancer, you can be more confident as time goes on. But things like breast and bowel, you can get relapses 19, 20 years later. Well, the drug company, I mean, as I say, I'm not criticising them, but they are businesses and they want to make money. So if they want to take over a natural product, such as this, because they can see a market, because there's a third of men now with prostate cancer aren't having intervention, and we know that 70% of men with prostate cancer take things to help themselves, most of them not evidence-based, mind you, and they want some of that market. But they actually can't if they can't patent it, they don't feel they're protected. So that's what they're saying. They want drugs which they can patent, and only they can sell. So they're not interested in natural food, carrots, or because they can't patent it, they can't make money on it. The worry with phytoestrogens, when you then take them out of the natural form and concentrate them, is that the binding to the receptor could get stronger than it would naturally. So you then do start getting promotion. And there is data on that. So for example, men with prostate cancer who took, I can never say the word ginseng, they actually showed there was no effect on PSA, and actually their insulin-like growth factor receptors started going up. So there was another experiment with monkeys which gave them, and they had endometrial hyperplasia.
So you're talking about soy in the diet?
Yeah, dietary soy. So, I mean, if you have no soy in your diet at all and you take a low dose supplement, it probably does you good. But, the danger is when you excess on it. And in terms of, I mean, I can't recommend POME-T to my patients.
Why not?
because, well, you can't promote long unlicensed products, basically, and it's not licensed.
So how did we get to hear about it?
Because it was on national TV and it was in front page of all the papers in Bedford for a start and Cambridge, so and people talk to each other. So especially the prostate cancer community. So there's advocacy groups and it's been in loads of newsletters and things like that. So they find it. They can ask me advice and I say, well, you know, it's evidence-based. And some of the Cambridge consultants I work with are saying, well, look, if you want to take something, take that, because at least there's an RCT behind it. So oncologists are liking the data, if you know what I mean. But you definitely wouldn't say it is instead of a healthy diet, it's as well as, you know, and as well as exercise, you know. Yeah.
People's natural tendency is to
I don't think so. I think the people who tend to, I mean, the best example I had is a man who had growing cancer in his lymph nodes and his abdomen, a couple of lung mets. He, you know, did the whole package. He exercised every day, lost weight, stopped smoking, stopped alcohol, cut out all carcinogens, well, as many as he could from his diet, started taking Pomegranate, got a nutritional test and took 1 or 2 selected. He was zinc deficient. And you know, literally the response to his cancer was almost the same as chemo. And you know, he's a classic example. He's an extreme, but most people, if they're going to go down that line, will also exercise. And that's my experience. I don't know if it's yours. Oh, lots of questions.